Good morning, everyone. Hope everyone is great on this Friday. I was just waiting a few more minutes for more people to join us, but I think we can start because we're starting with a recap from yesterday so people can join us on the way. Yesterday was so much fun. I was actually, this morning was just looking through some of my notes from yesterday and just thinking about today and the more stuff that we're going to discuss. Just to go through the agenda quite quickly. So, like I said, we'll just summarize a little bit here and there. And it's not just about summary, but I just wanted to have an open ended session where I do less talking and more listening. This will also help as I put together the report about the training because perhaps there could be other opportunities to do more meetings or workshops to better support community media. So I think I would like, yes, to recap, but also to kind of talk about, I'd like to hear some of the challenges you've had covering COVID-19 and some of the support you think you may need and that could be offered to you through different entities so that I can capture that in the report. And then at 10 a.m., we're going to look at Writing 101. So this is just more about how to cover the pandemic, vaccine developments for our communities. And then at 10:30, we're going to have Candice Sihoma, who's from Doctors Without Borders Access Campaign. She's an advocacy officer there, so she's going to be telling us about she's going to be actually telling us about, I see here, I wrote storytelling and audience segmentation. That's actually not what she's going to be talking about. She's going to be talking more about equitable access. Like we said yesterday, MSF has been leading kind of like the fight for access to medicines in the country, in the world, actually, for a very long time. So she understands, like, you know, MSF has a rich history of how equitable access, some of the issues that Fatima was also explaining yesterday, she's going to expand on them. So that is going to be quite interesting, and I'm looking forward to it, to hear what she's going to say. So anyway, like I said, I just like, I think maybe let's start with thinking about yesterday. Any reflections anyone wants to share about how day one went? Are there any things that you expected to hear that you didn't, which is also great feedback to make sure that we are able to make the workshops better. So really, this is more of your platform. I spoke so much yesterday. I'm going to speak a little bit at 10 as well. So just opening it up to you guys to share. No pressure. There's no reflections. Please don't make me choose anyone. I don't want to choose. I also lecture adverts, and when I do lecturing, my worst thing is having to choose. My worst thing is having to choose anyone to speak. It's like, I hate it so much. Please don't make me do it. Come on, guys. Please just don't forget to mute yourself when you enter the room, just to not disturb. Lungi, I see your hand is up, so please go right ahead.
Good morning, everyone.
Morning.
Oh, okay, great. No, for me, my reflection would be on, the importance of us understanding, us as journalists, understanding exactly what the message, not really what the message should be, but the right way of messaging all the information that we have about the vaccine to our readers and to the community at large, because it's not just our readers, it's also the people that we interact with on a daily basis, be it via Facebook or WhatsApp. I was shocked recently when one of my sisters, sent me a message speaking about this whole theory, the 5G theory, and she actually believed it. And then that actually made me wonder whether I was doing my fair share of good when it comes to, like sending information that I have to not only, like readers, but to the people that are close to me, And I was quite pleased to that she actually came to me, with this information, sort of using me as a soundboard, to see if what she was hearing was really correct or not. So basically what I'm saying is, we have a responsibility not only to our readers, but to those close to us. And we also have a responsibility to ourselves, because I always find it awkward. Like I remember when we were reporting on TB, you'd find journalists going to hospitals without masks, going to like trying to enter into TB wards, and the basics, they wouldn't follow themselves. I don't know if you guys understand get what I'm trying to say with this.
Thank you so much, Lungi, for that. Like how this information, I like that example that you said about how this information can also help protect us as journalists when we're going out, even though we're not frontline workers like the health workers, we sometimes have to go into the same spaces as them. And if we don't know the preventative methods or how to ensure that we're safe, we can jeopardize ourselves. I think I saw a lot of that also in the beginning of the pandemic here, where people didn't really take good care of themselves. You found journalists. I remember seeing a friend of mine who's a broadcast journalist on TV with gloves on, and she's holding a mic and she's obviously crossing over. And I had to message her to be like, no, don't, wearing gloves is actually more dangerous than not like just washing and sanitizing your hands more often. And she's like, oh, shucks, I wasn't aware of that. And I thought I was protecting myself because I'm always out in the field, in the communities. I was like, no, but those gloves that you've touched everything with, you've now touched a mic, the mic that you use, that's very close to your face, that's very close to your body. So if there is droplets of COVID, of corona, it might end up on you anyway. And so the information is also there to safeguard us, particularly if we are out in the field doing the reports. Thank you so for that, Lungi. Is there anyone else who'd like to reflect? And also not just reflections, like I said, also sharing the challenges that you may have had over the past year covering COVID. What are some of the stories that you wanted to write or investigate that you were not able to, and why weren't you able to do it? Was it a matter of not being able to get answers from provincial government or even national government? Like, what are some of the challenges, or what are some of the factors that make it hard for you to cover COVID?
Poncho, if I may.
Yes, please do, Mahmoud.
Okay, just two things I wanted to say. Number one, I found Fatima's presentation very helpful today, particularly because I think the health justice initiative, the agenda and the objectives are pretty consistent with what we're trying to do as a newspaper. Muslim Views is focused very much um, on social justice issues. So I thought that in order for us to find more benefit out of it, and following up on your question on whether there's any suggestions that we can make as far as getting more benefit out of this kind of presentation, I was thinking about the kind of investigative stories that one could do with health institutions, both private and public, within our own communities. Now, I might be speaking for some other media organizations like the radio stations and other newspapers, but our newspaper in particular, we are in a community where a significant proportion of the people actually rely on private health care. And they go to the local private hospitals. And the social justice divide that we have in South Africa, in fact, throughout the world, is very stark and is greatly, the contrast is very stark in our own community, where the poorest of the poor have to rely on your local day hospitals and the public hospitals. But there's the divide then of those who rely on private healthcare. And I think I would like to be in a position as a journalist to look at what kind of health provision there is within these hospitals that sets them apart, not just in terms of the social status that they enjoy, but what other infrastructural, political, and social um, underlying factors are there that privileges these people above the poor. And particularly if those factors are connected with corrupt practices, with the kind of pricing disparities that we see, that we heard about yesterday, that Fatima spoke about, very clear pricing that you can see certain products and services are kind of reserved for the rich, and others are for the poor. And there's clearly an economic motive behind that.
Yeah.
So is there something specific regarding those kind of practices that we can look at within the private healthcare system, and even the public healthcare system for that matter, because corruption happens in the public space as well, as we know. So maybe a session on the kind of leads one can look at for identifying corruption in healthcare within our own communities, particularly as it relates to the disparities between private healthcare and public healthcare.
Okay.
That's a one point I would like to make, one question that I'd like to put. The other one is slightly different. I was contacted about 2 weeks ago by a medical doctor who was interested in a completely different story we published on sexual abuse within the Muslim religious institutions. So we did the story, and he responded and saying, "Look, this is just what we call fitna mongering. In other words, spreading rumors." The story was very well researched and it was based on fact. But I didn't know the background of this gentleman. You know, when he explained to me that he is from Johannesburg, he's in Cape Town with a couple of doctors, and they're doing the rounds to do talks in the community about COVID-19.
Mm.
And what they're specifically doing is, to put it crudely, spreading conspiracy theories. In other words, they're questioning that this virus exists,
Wow.
that that the um, that the sicknesses and the fatalities that we're seeing is as a result of the virus. They're relating all this to the 5G towers and all of that. And he wanted me to be part of a 2-hour presentation. So I said, I'm going to I'm going to entertain them. And for 2 hours, I sat through a presentation. It was a virtual presentation. And at the end of it, I asked him, could you please leave with me your presentation, in other words, the PowerPoint and the contact details, because I would like to set up a further query of the presentation that you've done in order to speak to professionals in conventional medicine and healthcare to engage. Because I'm a journalist, I'm not a healthcare specialist.
Mm.
And I would like, if I was going to give you a platform in our newspaper, I'd like to present a fair and balanced story.
Mm-hmm.
Now, I want to come back to this fair and balanced story approach in a moment. But when I offered them that opportunity, and I said, I await your presentations and I await your response to my invitation, I never heard from them afterwards.
Sure.
But they've been doing presentations around the city, around Cape Town, sorry, for about a couple of weeks. And when I asked them for feedback or for the presentation, I never heard from them. And I don't expect to hear from them. Why? Because when I said to them, I've got doctors in our own community, people that we know, people that we've relied on, people whose work we've published in our newspaper. I'd like them to engage you and ask you the critical questions. For example, what evidence do you have that the virus does not exist? Well, they're putting the question quite differently. Is what evidence does conventional medicine has that the virus does not exist? Have they actually isolated the virus and so forth? Now, these are kind of scientific issues which I wasn't able to engage, and therefore I thought I'll get the medical doctors to do that. Um, that never happened because they never came back to me. But
Mm-hmm.
what they did was they sent me links to a number of different publications which are apparently academic studies, which are research based, which are evidence based, and which they are using in order to put their arguments forward. Now, I was looking for a few minutes just before we started the session. I'd like to get a list of these publications and maybe share it with everybody. But like I said, because we are journalists and we're not healthcare specialists, we need the people who are in the know, the specialists whose research areas this is, to look at these kinds of claims from actual so-called academic studies, like this Lancet journal article that you referred to yesterday. And there are many like that today as well. So, if I may, I'd like to share that. And if there's any response that you and others have as to how we can engage the claims made in these publications, and then I think it might be useful for us to interrogate that and publish material and content relating to that in our newspapers and even broadcast it on the radio stations.
No, definitely. I mean, there is a lot of people who are purporting to be experts going around trying to, like the point that I was making yesterday around some research looks legitimate and only to find out that it's being funded by suspicious funders or by the industry that wants this research to look good. And so it's very great that you offered that person a chance to show their work, like to give you the work and so that they can be challenged by experts. I think, a lot of the times if we do write stories about this, especially Mahmoud, you're saying that these people are going around in your community, right? And they're spreading this information. So I would think just thinking from like a health journalism perspective at the top of my head, a story would be writing about these people, describing them and the experience that you had like you did, and that they're going around. However, when Muslim views tried to get them to speak to other professionals, they refused. And then you start talking about the misinformation, but then reporting on the truth, right? So offering that, however, science has not seen that it's possible that 5G or whatever else conspiracy theories that they were purporting cannot be true. So it's kind of like balancing. That is a story in its own, especially if you like, by your observation, you're saying that they have been going around in your community already giving these presentations. So the information is out there, it's spreading. How do you contain it? You can't really contain the fake news by ignoring it, right? So you acknowledge the truth or the reality that this misinformation is being spread out in the community. You acknowledge it, you describe it in a safe way. So like, I usually advise that you don't really go into too much details of the presentations, and whatever details you go into, if you're quoting them, you counter the quotations of the fake news with what science actually says. And then you interview an expert, somebody who's more reliable, who's reputable, and you counter all the reporting on the fake news with the truth. And I think that's how you can find a balance. And we'll talk about this, actually, there's a slide in my presentation for 10 o'clock where I kind of also talk about how to deal with misinformation, how to report on misinformation without spreading it even more or creating more harm in the community. I hope that answers you, but thank you so much for that, even for your suggestion around how private healthcare works. I think, according to the latest Stats SA, I checked it about a month ago, so I'm sure it's still the latest. 84% of South Africans actually use public healthcare system, and only 16% of South Africans actually have medical aid. And of that 16%, what we see happening is that before even before the year is done, a lot of the people who have private medical aid, like who have medical aids and use private healthcare, end up having to start supplementing their healthcare needs, going to the hospital for flu, for contraceptives, for whatever basic, professional, what we call primary healthcare. They end up having to actually go into to public hospitals because private healthcare, that they've run out of medical aid savings, or they actually end up having to pay cash anyway in the private sector if they're going to see a GP. So I think the inequities of private healthcare, which was a very big conversation at this time last year. I remember last year at this time, I was finishing off driving across 9 provinces for the NHI public hearings, right? And then COVID happened and that conversation kind of died out. But I think this offers us an opportunity as journalists to also kind of bring up the conversation of the national health insurance or universal health coverage for all, and COVID-19. And what has COVID-19 taught us, or what can we see from COVID-19? What are the lessons that we can take in to make NHI or universal healthcare coverage possible? And these are questions that you can pose to experts, people who are public health experts, to ask them. In the past year, especially with the anniversary of the anniversary of the first case in South Africa coming up. So we're a year in. What have we learned? What have we learned as South Africans about how we need to fix our healthcare system to be more equitable as well? What has COVID taught us about how our health system works and whatnot? So these are some of the ways, but we'll also talk about it later when we talk about different story ideas and how we can take the conversation forward in ways that matter and are useful and helpful for our communities. Alison, and then Dumelo. I'll also read
good morning. Oh, sorry.
Morning. No worries.
Oh, good morning, Ponzo. Good morning, everyone. Yeah, this has been, firstly, thank you so much for yesterday, and even now I'm learning a lot, and it's good to be in company like this. Um, in 2020, I struggled a lot with the lack of transparency when it comes to your government agencies, and specifically, I'm trying to I'm trying to not point to a specific department, but I'm going to say it. The government health department. These organizations all work through the media liaison officer, and whenever there's queries or questions on stuff, then we have a media statement that is issued in response to it, but it sort of straps one, and limits the extent to which one can truthfully report on an actual situation. Something like PPE, for instance. Whatever questions we have, I find that our healthcare workers um, are hesitant to truthfully speak to me when I chat to them in my media capacity. But I think that there was one article, there were three articles, in fact, that I wrote in one of the months in 2020, which, after I saw a little protest happening, I wrote to my editor and I said I would like to withdraw my articles, because I was helping to convey a message that all was okay, and I could see that everything was not okay. So that kind of, I think, holds back a lot of um, potential improvement that we can see in our government systems. I mean, and the same goes for the Department of Labor, the Home Affairs, and all of those, where um, there's valuable questions from the community side that could be posed to these departments. And if they even bother to even look into it and look to investigate, and in order to give us feedback with corrective measures as well. I think the role of the media could be so much more, for the communities out there. I like to, first and foremost, I like to create change with whatever I do, but because of this notion of, and I've seen that with workplaces as well, that whenever questions are posed to them, for articles and stuff, it just basically ends with a media liaison person issuing a statement, and then the whole thing dies, and that's kind of been disheartening, because we don't see the changes that's needed. I come from a scientific background as well, so these questions I ask, and I actually try to edge them on with some suggestions and stuff, and I don't see much of it, changing after questions are posed, and some of the questions actually just go unanswered. So the lack of transparency, or I almost feel like they just batted away, because they are so stuck in whatever plan and program they have. So that makes it real difficult for fair reporting. And then on social media, we see healthcare workers and whoever else, write from their personal experiences. Yet now we're sitting with a social media post, which your sensationalist um, would report on, but then it just becomes a sensational story. There's no real value to something like that, which I find to be a major challenge. Thank you.
Thank you so much, Alison. You raised really great points, right? Like, there is, I'm not going to sit here and defend the Department of Health. There's a query that I sent in for a story that I was supposed to submit in November. I am still waiting for the answers now. So in my other capacity, I train I train government communicators. So last year when we did the course, right, I created a space like this almost as well, to be like, what are the challenges you as government communicators face in communicating to journalists, to the public? And I think I had to even report it back to GCIS to say, one of the biggest factors is the fact that the communicators, the media liaison officers, the communication managers that are in government are also frustrated. And it's, from my understanding and from really talking to the government communicators, the problem is the bureaucracy within the government system on how media queries are dealt with. So you send a media query to the communication or media liaison, they have to send it to the HOD to get the answers. They cannot send you the answer. They then draw up the answer for you. Then they have to send it back to an HOD to approve that they are giving information, they are comfortable with the information that is being given. And a lot of the times the backlog is there with non-communicators, non-media people are being the gatekeepers of information on behalf of or on behalf of the communicators. And then the communicators themselves, they can't do anything. And this is not to also kind of scapegoat that the fact that government communicators could communicate better and more efficiently, but the lack of transparency is, and I think I mentioned it quite briefly yesterday, talking about that there is a trust deficit between government and the media and the people, right? The government doesn't trust the media. The government doesn't trust people, its citizens, the people who have elected them. And in turn, we don't trust them. And so we find we're doing this back and forth where we as journalists also sometimes we're out to catch out governments. I was in another meeting yesterday after the workshop talking to activists, and they're like, sometimes it feels like the media is also out to get government, like to catch them out. And so there's this trust deficit, which when I look at it from anyone's point of view, I understand why it's there. It's not right. And there's certain things that really need to change within government to ensure that communications is much easier. For example, when we had the briefing on the 3rd of January about the vaccines and how they're going to be rolled out, some of the documents that the Department of Health released were dated as late as 15 September, right? There was no document that was dated beyond 15th of December, I checked, right? Which means that there was already progress and there were things that were being done in the background around vaccine procurement, making sure we have enough doses, what the plan is going to be when we receive the vaccines and whatnot. But until there was enough public outcry from activists, from media asking government, what is happening with the vaccines? Why are we not getting vaccines? The government said nothing. This is why they had to have an not an emergency, but the presser had to happen at a time that they had not planned for, right? Because there was public outcry. And I look at this and I'm like, this information could have slowly been given out, right? Maybe before we went on the Christmas break, just a media statement that although there are certain contracts that we cannot talk in detail about because we've signed non-disclosure agreements, this is the progress that we are on in acquiring vaccines for the country. We cannot share more information because XYZ and ABC. But we do not have that proactive communication from the Department of Health, and I think from many departments and from government as an institution, which creates this trust deficit. And in between that, we are stuck as journalists with the frustration of I can't have a story that says, we can't have a story every week or every day if you publish every day that says government did not respond to this. We sent a query to government, but government did not respond. So what happens is we end up having to cut a lot of our stories and not actually publish them. And so this is how then we have to become innovative in how we report. And we're going to talk about that a bit later, about maybe more first-hand experience stories. So the example that you gave, contacting or going to your local clinic, your local hospital, waiting outside, or if you do know doctors and nurses in there and saying, hey, I'll guarantee your anonymity. I won't reveal your name or your details, but tell me your first-hand experience about being a frontline worker during a pandemic. What are the shortages? This morning on Motsweding FM, they had a soundbite by a nurse who's talking about that they're expected to reuse a mask 5 times or use it for 5 days before they get a new one. So we're really back to PPE shortages. How do we report on that in a fresh way that will not also cause panic? Is those first-hand experiences, and in that way we also alleviate our dependence, which is inevitable because we're journalists, on needing a government response. I hope that makes sense. But your concerns are duly noted, and everyone is complaining about the same thing. I was even told by the Department of Health. I sent, after the vaccine press release, I sent about 25 questions, media query, and they told me they simply just cannot answer my 25 questions. And I called them, I was like, what do you mean? They're like, we just really can't. We don't have the capacity to do that. You're asking important questions, but I'm telling you now, I'm not going to get the answers from my HOD or for my political principals. So it's quite something. And I'm seeing the chat. Let me just, before I get to Dumelo, go through some of the conversations that are in the chat. Henrik talking about how the importance of us reporting, essentially, if we don't report properly, we're failing our people, which is quite true. And that is also something that is quite important. Sikelela also talking about separating fact from fiction and always trying to make sure we have the right information, which can be hard when you have a government a department that lacks transparency in how they offer information and how we get it. And Lucas also just contributing around the facts and using facts and not assuming, and being very, very deliberate in ensuring that we are not misinforming our community. Tidiso also talking about the trust deficit, talking about how government doesn't trust us as the media and its own citizens because they're busy lazing around and doing all the wrongs. As Fatima said, we are led by a government that is not transparent and about being outsmarted. That is very true, Sidi. So I try not to, because I have sources within government, and I know many journalists do have that. And I do know that there are people in government who are working, but the system is just continues to fail everyone. And this is why, sometimes I know things, but I can't report on them. I know them off the record, and you just had to find a way to try and put them into a story, but it's not possible because you might jeopardize your sources. But we do need a more transparent government that gives us information. And it's one of the frustrations, it's one of the things that makes journalism hard for all of us, I listen also talking about how we're not allowed to speak. They're not allowed to speak to me. They say, I have relatives who are too scared to speak to me. I know, and this is why, a lot of the times when I interview government healthcare workers, I have to, make lots of promises. It's also a dance, right? It's it's a courtship. It's like trying to woo and impress somebody you like, so that I gain their trust. I've spent 2 years speaking to someone who does not want to say anything on the record and eventually does. And this is kind of part of the game of journalism, is that you have to say, no, I'll keep you safe. I won't mention the hospital or the name or which department you work in. And I've seen, even when I was the editor at Health E-News, when the citizen journalists there would also go into communities. Once you build that repertoire, and it takes a long time sometimes, those people become your sources for the next 10 years or for the next however long you need. But it's very important that we ensure their safety. I think one of the biggest kind of scandals about a health workers who was not protected was the Sunday Times saga, where they reported on the late former health minister, Manto Shabalala Msimang, needing liver surgery, right? Like she needed a liver transplant, only to find out that she was a diagnosed alcoholic, and how, because she's a politician, because she wields so much power, she was able to get on the liver transplant list earlier, despite the fact that she had a drinking problem. And so what happened in that case is that the nurse, when I think, if I remember correctly, the details might be a bit patchy, but essentially it ended up going to court, or to, it ended up because it was a breach of privacy she gave, the nurse had given the journalist her medical records and whatnot. But eventually, I think the journalist should have protected the source. You know, this was a public interest story about a politician, not only just a politician who was a health minister, abusing her power, right? Abusing her power within a hospital. And this woman was a whistleblower, and she was not protected. She had to immigrate to New Zealand, I think, because there was a criminal case against her because she was revealed. And so also understanding why nurses and doctors don't want to speak to us is because that there are instances, public instances, where our colleagues have broken their trust and they've ended up in trouble. So the onus is on us to ensure that we build the trust with them, and make sure that they trust us. It is on us to build that relationship, and it fails a lot of times. I'm not going to lie to you, as somebody who has had to, like, all I've done for the past 3-4 years is report on health, is that 80% of the time I fail, but the 20% of the times where I've succeeded to win the trust over of a government healthcare worker, it has worked out the best for my stories, and to also understand what is happening within the government, even if sometimes it's something I can't put on the record, but to have the background to be able to ask the Department of Health or send questions to that hospital that are pointed. You know, I'll give you an example. There were babies who were dying in a hospital here in Gauteng, and it was not being declared, right? One of my sources told me, and so when I sent my media query, and one of my sources, she actually sent me some of she pulled it off, she was a data capturer at the hospital. So she pulled off the data of the government server, and she sent me the causes of death. And so this is obviously, it's illegal, but the public good. There were 5 babies who had died. It wasn't known why they had died. So it was it was in the public interest to write the story. When I sent the questions to the hospital, I could send pointed questions because I knew. So it's that you might not always be able to use the information on the record, but it can allow you to use the information to ask questions that give you answers for a bigger story, or in a different way. So I think nurturing those relationships, especially on a community level, I think you would be able to get some of the best stories ever. It's just, it might take 6 months, it might take a year to win the trust over of the healthcare workers. Dumelo? I think you're still muted, Dumelo, if you're speaking. Okay, I think maybe Dumelo is not hearing me.
Hi, hello. Oh, yes, I can hear you now.
Okay, awesome.
Okay, morning everyone. And thanks. I think Ponso and Alison have already said everything that I wanted to say. The only challenge that I think I'm currently facing, because I'm from the deep rural areas of Bushbuckridge in Mpumalanga. When it comes to the vaccine, I think in my area where I'm coming from, it's going to be a challenge for people to take the vaccine because of the videos that they're going through our social media, Facebook and everything about the 5G thing that they're talking about now. I was in a point whereby I told myself that I'm not going to write any story that is to do with the COVID-19 vaccine. The reason being is because you go to government asking for a comment, those people, they tell you that they don't know nothing. they'll come back to you. It's either they come back or they don't come back at all. So
Is
if we are lucky,
is this provincial government?
It's our provincial government. And then lastly, another challenge that I think if we are not going to pay attention to it, it's the one that I think is spreading the disease. I have noticed that most of our retail shops, I'm not sure about other provinces or other districts, but in Hazyview, where I'm from, and that other part of Bushbuckridge, Akonhoek, I have noticed that in those grocery stores, if one of the workers there, they get the disease or infected something, they only send one worker home. The rest, you must continue to work until you show symptoms. If you don't show symptoms, then you continue to work, even if you're sick, because there are some people who are sick, but they don't show the symptoms. And then now you go to that shop, you interact with that particular person is infected, and then you bring the disease back at home. And then the problem is most of those retailers, they don't matter. Nowadays, and then you take the story to the provincial government, but this is happening in the shop, thinking that they will attend to it, but they do not. That is the biggest challenge. That's why I've been saying I'm stopping to write about COVID-19, because it has become useless. They come to report you thinking that you'll come up with a solution. You go to those people who are responsible maybe to resolve that matter, but they are not solving the problem. So I think this is one of the challenges. But after yesterday, just listening to Fatima, she has encouraged me that I can still go back and write, maybe help some of those people from my village or other villages in Bulgaria. No, you can still take the vaccine. They must forget about these fake videos that are circulating on their social media. Because another problem is that they will watch that video, then that's it. They won't even go back, maybe read your story, or just to say, no, but this thing was just a video that was created by someone with their PC. Maybe that's software they can do it, but they won't ever get the chance to maybe read something so that this video was fake, but they will believe to it now. That's why you can, if you can come in my village, you'll laugh. Everyone in the morning, they are using the Msonyane. They are using all these things just to steal so that they can try to kill it, because they don't believe in that vaccine. Maybe that vaccine will work.
Sure.
Thank you.
Thank you so much, Dumela. I think, some of the things that you're saying are so important. The fact that there is still so much, what we call the public health term is vaccine hesitancy in our communities, right? And this is part of the reason why the failure on government communications is important, because they need to also be countering the messaging quite aggressively. And with that, like for instance, you're talking about, I think for me, like just thinking about when you're saying that one person in a store tests positive, but everyone else who was in contact with that person is not asked to quarantine. I think the important thing is to send a media query to the head office of that chain store to say that one of your stores is not compliant. This is what happened. I'm writing the story. What is your comment, right? That is how you can write it. And then in the story, you say, you explain why maybe you find a doctor also to help you explain why what that store is doing is incorrect. And these are the ways in which we have to take the personal experiences or the experiences that we see in our communities and use them to create content for ourselves and for our readers to ensure that our community is informed. So for instance, even with regards to I often name and shame the government when they don't respond. Like I'll go onto Twitter or Facebook and say, I'm not getting a response for my query or whatever. And lo and behold, a lot of the times they'll call me or something. So sometimes it's also pulling rank. And I know it's difficult to do it from a community media point of view, because sometimes your community newspaper or your radio station also depends on funding or advertising from local government, and you don't want to savor that relationship or damage it, that it could affect how much money you get, or it could affect other stories. So I think it's a very difficult balance, but persistence, and sometimes, like for instance, Chiwa is going to send you, she's going to send, today when she sends resources, there's a booklet that was created by government on vaccines, right? And everything. That information has been vetted. You don't necessarily need to interview anyone. Maybe you need to interview one or two people, maybe a doctor and a nurse, just to have a quote in your story. But the information about how the vaccine works, why the vaccine is safe, is in that booklet. And it's a resource that is reputable. So you can quote that document, and instead of relying on necessarily government, if you're doing an information like story, maybe how to understand vaccines 101. And so this is kind of ways we kind of almost need to find ways to skin the cat in multiple ways. And it's not easy and it's difficult. Just want to read comments also here. I know I'm supposed to go through the presentation, but I think this discussion was also important to talk about your actual experiences and how you are experiencing being journalists during a pandemic. Particularly, I think, the South African media industry does not do enough to support community media. And so I thought it was very important that we get into some of the difficulties that you're facing from a community media point of view, and thinking about also writing up the report. And I will personally send some of this feedback to the colleagues in government communications that I have very close relations with, to be like, but you guys really need to take community media more seriously. Mahmoud also sharing that the important point to make is that the fairness and balance in media is not necessarily a function of equal coverage of dissenting views on subjects like the COVID-19. This is correct. The media's commitment to fairness and balance is guided by the concomitant responsibility to prioritize the public interest. Very true. So for instance, you don't want, when we say fair, like I remember when in media ethics, they used to say fair and balanced does not mean giving equal. You're not talking to somebody who doesn't believe in vaccines at the same amount. You're not giving them the same amount of time as actual, or the fake news, the same amount of coverage as the truth, right? Or the scientifically verified information. But it's really also one of the major rules, or one of our golden rules as journalists, is to do no harm. And if you're spreading misinformation, you are doing harm. Like we said yesterday, right? Like with health information, it is literally a matter of life and death if we do not communicate the right and correct information. So you will be doing harm, which is like the cardinal rule of journalism not to do if you do give equal in terms of the fairness. It goes on to talk about that our cherished independence that enables us to use our discretion to determine what is in the public interest based on the standards of objective and factual verification required for their viewpoint to make the news. I'm confident that we have a consensus on this position, and to assert that COVID-19 denialists do not merit coverage because they do not meet the standards. This is very true. Like the example I gave of the story that came in one of the most prominent weekly newspapers, where all they did is quote a COVID denialist. Not at any point in that story did they say this. They said it's fake news, but they didn't combat the fake news with the truth. And we have to do that because we do no harm. For example, digital research shows that people do 4 scrolls, like on your phone. People scroll 1, 2, 3, 4 times when they're reading the story. And it's about 18 to 25 seconds that people spend on a story. That's where we are in life, just by the way, online. People do not read full stories. They scroll, it's about an average of 3 to 4 scrolls before they get out of the story. So if you're writing a story, let's say you write a story based on a COVID denialist, and all the information at the top is on the conspiracy theory. That's all people hear. That's all people read. And that's all the information that people read. And it's the same about concentration for radio, right? I'm more of a print journalist. So your nut graph can't just be the fake news. you have to work in the first maybe 1 minute. I don't know what the limits or the time frames for radio or broadcast are. You need to work in the truth, because people's concentration and attention has also decreased. And so these are ways in which we also practice safe and ethical journalism, when we take these factors into consideration, that people don't read the whole story. So if you put all the right information or the correct information about how vaccines work, what is happening with vaccines at the bottom of your story, or at the later end of your bulletin, you've lost so many people. And this is why thank you, Mahmoud, for making this point, because it's very, very important. As we wrap up, Lungi also says that, just to add on to that, one of the things that often have often helped me was creating strong relationship with communications officers at hospitals. Very, very true. I'd make them understand that my stories are not aimed at catching the hospital out, but to assist the community and my readers, sources for my stories, and the sources of my stories. Sometimes this worked out for the best, because some would go as far as giving me information that is not included in the approved media response. This is true, you know, communication officers, most of them, one, were journalists at some point anyway. So they are on our sides. You know, no one goes into this field of work of communications and media without having a love, a passion to community. So sometimes building those relationships with the communication officers benefit you most, because even when they're superiors, I know so many people who have had some of the major leaks that even have happened during COVID about some of the corruption and everything came from government communicators, right? Who know it's wrong, who are not, you know, like, obviously they work there, and you know what happens when you work for a company, you don't necessarily always agree with everything for them. So building those relationships is very important as well. Dumelo, also just going back to the issue of most of the retail shops in Bushbuckridge, most of the retail shops or their head offices hardly respond to our media queries, especially from the local media house, unless you pretend to be a mainstream media. I was about to say, you sometimes have to pretend, right? Like, and this is also something that I'm very cognizant of, that it is easier for mainstream journalists, or not mainstream journalists because we're all mainstream journalists, but national journalists or more prominent journalists to get responses, because communication officers or even the departments of health value them more than they value us. So I think it is another factor. And these are sometimes you have to lie, you know, you say, you have to threaten or pretend to be from another publication. And it also helps if you have a friend or you know colleagues who are at larger publications. So you say, hey, can I just say I work with you or something like that? It also helps quite well, but it is a difficult situation. I am so happy that we had this discussion. I think it really revealed a lot of interesting factors and some of your challenges, which I have duly noted. And I think together with the African Alliance team, we'll also just think about if there are other opportunities to support you in making sure that you don't have these challenges, particularly during the pandemic. We will obviously stay in touch with you. And with that said, I can see Candice has arrived, and I would just like to welcome her and thank her for, you know, taking her time out of a busy schedule to come speak to us, and also to talk to us about equitable access. As I said, that Candice works at MSF, Doctors Without Borders, and she is the MSF Access Campaign Advocacy Officer, where she advocates for access to affordable medicine, diagnostics, and vaccines. And she does this through advocating for the adoption of policies, laws, and practices that safeguard public health. And she's obviously going to tell us more about these laws and policies. And when she was in university, she founded an organization called the Building Blocks Foundation, which seeks to improve access to quality sanitation by eradicating the use of bucket toilets, replacing them with proper flush toilets. She's very passionate about human development, particularly ensuring that people who would otherwise be excluded from the healthcare system get access to quality healthcare, which speaks to some of the also stuff that some of the points and issues that Mahmoud brought up earlier about this is an area of interest and that possibly more information on this. Welcome, Candice. Thank you so much for joining us. And I'll just give over to you. I think you should, I'm not sure if you are able to share your screen. Do you want to share your own slides, or would you like us to share them on the side?
I think I can share my screen. Let me just double check.
Okay.
Yeah. Okay. So yeah,
Awesome.
I think I should be able to do that. So yeah, thank you so much for that introduction, Bonto, and thank you all so much for having me here today to share a little bit of what I do and the work that we do in advocating for access to medicine, vaccines, as well as diagnostics. I think I have a problem with my video, so it might freeze every now and again and then come back. Sorry about that. It's a laptop issue from my side. And also I don't really have that much good bandwidth. So I think I'll have it off, but I just thought it would be good to see my face at first. And then, yeah, I'll just present my, share my screen and start the presentation. Can you see it?
Yes, we can, Candice.
Okay. Okay, so yeah, so as Bonta has introduced me, so I'm Candice Homa, and I'm the Access Campaign Advocacy Officer working for Doctors Without Borders, and I'm based here in Johannesburg. So I think just to talk you through what I've prepared for today. So I think the main thing we'll be talking through the work that we do in South Africa, mainly our work in advocating for patent law reform in the country. So that will be pretty much the focus. It also ties into much of the work that we do in advocating for equitable access to vaccines, diagnostics, as well as medicine. I think it is rather useful to also take it from an angle of like the policy and the legal framework in South Africa, and how is it assisting in our fight for better access to these medical products. So just a bit of a contextual background, which I think you probably do know. So some of the public health needs in South Africa. So currently, as a stand-up, we have about 7.5 million people living with HIV, and 5.2 of those people are currently on treatment. As you might know, that TB is the leading cause of death in South Africa. So also much of the work that we do at MSF focuses on advocating for access to better access to TB treatment. As you might know also that non-communicable diseases such as hypertension, cancers, diabetes are growing in SA at a high rate, making us very vulnerable to the COVID-19 pandemic, given the burden of underlying conditions and under-resourced healthcare system. Currently, South Africa spends about 8% of our GDP on health, which includes purchasing of medication, and I think it's also a very big percentage also that goes into the purchasing of medication, because South Africa is also not sort of financed by these global mechanisms or international funding institutions. In most of the cases, we rely on ourselves, we basically self-finance in purchasing most of these drugs. And also knowing that 80% of the population relies on public sector to access health services. So in terms of the Access to Medicine campaign, so this, particularly from the MSF side, so this the Access campaign was founded on the principles of making medicine affordable, available, and accessible. So the campaign was started in the early 2000s at the height of the HIV and AIDS pandemic. And this we realized that multiple barriers and still prevent access to life-saving medicine. These barriers include, it's very much systemic barriers as well. This be policy, laws, certain ways of doing things and implementing things. So there's different barriers that we've identified, and therefore the Access campaign was set up to respond to these crises by overcoming barriers that prevent access to medicine and stimulating research and development in areas of public health needs. So today I'll also just mainly highlight one of the barriers that we have identified that stands in between us getting access to these life-saving medicine. One of them is the IP, also known as intellectual property law, that basically affects or influences how we actually access these life-saving medicine. So we have in the IP sort of legal framework, there's a thing called a patent, which is often given to pharmaceutical companies when they have produced or rather they have developed a medical product, be it a medicine, a vaccine, or a diagnostic tool. So a patent is rewarded and given to a company for inventing something new. I think emphasis on the new. And I'll also highlight why the emphasis on new. So this patent is given for 20 years, and basically that company is protected for 20 years. And that means that only patent holder can make, sell or produce or import that invention for 20 years. So it basically blocks other companies from producing the same thing that particular company has produced. We find that a bit problematic, and I'll explain why. So as you can see that this is just a diagram, a representation of how a patent sort of system looks like. When you grant a company a patent, that means that one company is the sole producer and provider of that particular product, meaning there's no competition, so there won't be any generic entry into the market because you have this company that makes it difficult, or rather prevents others from making the same. And that means that they can sell it wherever they want to, so they can register the product wherever they want to, at whatever price that they please, because now there's no competition in the market. Therefore, we basically run to them to get that particular product. So they can price it as much as they please, and which is what we actually get. Most of the cases that as a result of these patent protection, it basically allows for companies to profiteer out of these life-saving and often life-saving medical products. What we are calling for and what we have saying is that, we, especially considering, especially working with medical or rather in the public health space, we don't feel that the system should sort of apply, especially in the case of a life and death situation. So in the case of a system that has no patent, that would mean that there's many companies making the same product, meaning there is more competition, and which often would result to better supply, or rather more availability of that product, but also in terms of the pricing. And because there is competition in the market, that means that companies would compete to actually attract more buyers into their companies. So what we have actually in the international law is what is called the Doha Declaration. So basically on this Doha Declaration, this is where they introduced TRIPS flexibilities in realization of some of the limitations that the system or the IP system would have on public health. So these TRIPS flexibilities were introduced to protect public health, and therefore countries would sort of introduce those particular flexibilities into their system. Whilst other countries like India, Argentina, and Thailand have implemented TRIPS flexibilities, South Africa until this day has not, which is quite interesting considering all the different public health issues and public health issues that we have in the country. We still haven't introduced our TRIPS flexibilities into our national law to safeguard public health and ensure access, which is what we are calling for as organizations like Doctors Without Borders. We do this work so in coalition with other organizations under the banner of Fix the Patent Laws, where we are trying to push for South Africa to incorporate these flexibilities into our national law. And I'll just quickly highlight some of the flexibilities that I included on these trips. So the one being our current system. At the moment, we don't have, so we have what is called a depository system. And that means that South Africa basically grants patent to any company. So all you need is basically, an application form and an application fee, and you're granted a patent without even examining whether you qualify or whether that particular product is worthy of being granted a patent. Our criteria is quite minimal at best. So the first one being TRIPS flexibilities that need to be sort of incorporated into our law is the patent examination system, where we have actual examiners, scientists or chemistry sort of experts that will be able to examine, these patents that are being applied for in the country and qualify whether they should be granted a patent or not. Secondly, it's a strict patentability criteria. As I mentioned, that we have a depository system. We don't, at the moment, it's just a very minimal criteria where you're supposed to have these two things, and you're basically granted a patent. And another thing is also the pre-grant opposition system. So even if when a company applies for a patent, at the moment we don't have a system that would allow third parties like civil society or any other sort of party to challenge the granting of the patent. And also after granting of that patent, we don't have a post-grant opposition that would allow us to challenge the granting of certain patents. And as is the case, you find that South Africa, has a system where not South Africa, but what these pharmaceutical companies do is that they would apply for a patent, they're granted for 20 years, and what they would do is tweak just a small little thing in a molecule or just maybe the packaging or how the use of that particular product, and then extend their patent into some more years. And we have seen that even with a TB drug called bedaquiline, where it was granted a patent for 20 years. That patent was supposed to expire in 2021 actually, but Johnson & Johnson, what they did is that they changed a small molecule for it for them to be to have their patent extended, and therefore their patent is actually extended to 2027. So a similar thing happened in India, where they changed same thing happened in India, where they changed a particular product and applied for a patent. But because India has a more progressive policy or law, patent law system, they then sort of grant. Civil society could challenge the granting of that patent or the extension of that patent, and we in South Africa can't do that because we don't have a system to allow us to oppose or challenge the granting of these patents. Then you have patent revocation. So in the case if it's granted, you can still revoke, the granting of that patent. And another one is parallel importation. So this speaks to the importing and exporting of certain products that are being registered, or rather legally, that are legal in another country, and you're able to sort of import it into the country. And then the last one, being quite an important one also, is on the issue of compulsory license. And I think maybe you've heard quite a lot about this, that South Africa needs to grant a compulsory license. So this particular one, it is sort of reflected in our IP law. However, the current system in place doesn't make it easy for us to grant a compulsory license. So the process will take about 3 years and cost over millions for us to actually grant that compulsory license. So what we are calling for is for a more administrative process, because currently we need to go through a judicial sort of process, which is often very expensive and quite bureaucratic and very lengthy. And so what we would want ideally is a compulsory license system that is easy to sort of implement. And then when looking at comparing South Africa and other countries, as I mentioned, that in South Africa we actually grant more patents than compared to other countries. A study done by Fix the Patent Law highlights that in 2008 alone, South Africa granted about 2,442 patents on medicine. This is in Brazil, which from the year 2003 to 2008, Brazil only granted about 273 patents, which is very problematic if you notice, because ultimately it does affect pricing and access to these medicine. And here we also did a study, a case study comparing the price, the availability of certain medicine in South Africa and how much they cost. This is in India, where they do have flexibilities into their system, and how much each medicine would cost. And as you can see here, I'll just pinpoint a few medicine for you to see that lenalidomide, which is a cancer drug, in South Africa, in the South African private sector, you would get this medicine for about 3,308 a unit price. That's for a unit price, versus in India, you get that for 30 Rand for a unit. So that's a huge difference. And what we have also discovered in South Africa alone, for this particular medicine, you can spend about close to like $1 million in a year for this, for accessing this particular drug in the private sector, because it's currently not available in the public sector. It's the same with trastuzumab. At the moment, it's about 23,562. In the private sector, in the public sector, it's 10,596 per unit, versus in India, which is 11,687. So there's quite a huge sort of disparities in terms of the costing of medicine in South Africa versus in India, where they actually do have a progressive system and quite a booming generic market, where you have a lot of generic companies producing medicine. So coming back to our current times, I just thought that it would be useful to also maybe speak to some of, just outside of the medicine range, speak to maybe their diagnostics, as well, in terms of, how patents also affect access to these diagnostics, specifically now during COVID. We've seen that, earlier on in the pandemic, there were reports around South Africa not having enough testing kits, and I think we've seen that in, globally as well. For the majority of COVID-19 laboratories in the Netherlands, work with equipment made by pharmaceutical corporation Roche, which is also, we in South Africa use a similar product, diagnostic tool from Roche and depend on the company for supplies of the testing reagents. So there were reports of a shortage of this buffer of the reasons, and it's one of the reasons why Netherlands was not able to carry out mass testing of COVID-19 earlier on in the pandemic. So despite the shortages, Roche initially refused to provide the recipe for the buffer, blocking laboratories from quickly making their own solution and ramping up their testing capability. And what the Netherlands government did is that they issued a compulsory license for this particular product. What this experience highlights is how developing countries like South Africa would continue to have their COVID-19 medical tool response scale up hamstrung due to IP barriers, despite having the required capacity. Because in South Africa, as I mentioned, that we did have a shortage of these testing kits. And also we do have the manufacturing capacity to make these testing kits, but because Roche holds the IP and we're not in a position to actually to issue a compulsory license because of the current system, it makes it difficult for us to actually locally produce and respond better to the current pandemic. And so that also reflects how IP can serve as an issue, because now there's no sharing of certain know-how and IP and licenses to enable other countries who would have the capacity to produce to do that, because countries or rather companies, what they sort of protect themselves from others doing the same. So in the case of remdesivir, so the case sums up how patents can block access to therapeutics. So the primary patent on remdesivir was also sort of basically it was also qualified as one of the treatment and that can be used to treat COVID. So the primary patent on the base compound of remdesivir has been granted to Gilead in more than 70 low and middle income countries, hence potentially blocking access to generic alternatives until 2031. So Gilead signed secretive voluntary licenses with a few generic manufacturers of its choosing. So it wasn't like were not obliged, so they basically voluntarily chose which companies would produce these products to supply countries as determined by Gilead. As a result, other manufacturers in other countries with patents were excluded from manufacturing, and nearly half of the world's population were prevented from being supplied by their licensee. And when we can see is that because they actually chose a few companies to make the remdesivir, the price didn't necessarily go down like significantly. When you still have 5,000, Cipla was making a generic version for 5,000 for a 5-day course for one person, and Gilead was selling this, still selling this particular product for 50,000 for a 5-day course. So you can see the fact that Gilead still holds the IP and they actually still choose who gets it. It doesn't significantly change, in as much as, Cipla is making this product for a much lower price, but I think there's research that actually shows that it still can go down, it still should go down, also considering that there's been public resources that has gone into the development of remdesivir. It can still go down significantly if there was more generic entry into the market. So what we see in today is that several months into the pandemic, there's still no meaningful global policy solutions to ensure access. And what we see is that all governments are facing challenges ensuring timely, sufficient, and affordable access to effective medicine, vaccines, and diagnostics, and other essential medical tools. Considering that is like, nationalism that we've seen quite, heightened sort of countries keeping to themselves, shortages of these products because there's not enough, manufacturing capacity globally. and also pharmaceuticals are also still applying business as usual approaches where they still want to profiteer out of, out of this pandemic. So what South Africa and India has done is that they took a bold step with a joint waiver request to the World Trade Organization to prevent countries from enforcing patents, or rather granting patents on COVID-19 vaccines, drugs and diagnostics and other medical tools until most of the world's population has received effective vaccines and developed herd immunity. This process is still ongoing. So as I said, it was just a proposal from these two countries, and what is required is that it's for the countries to actually support this waiver and vote in favor of the waiver for it to be passed by the World Trade Organization. And the reason why this was proposed by South Africa and India is it's in direct response to greed and structural challenges governments in low and middle income countries face, scale up their manufacturing and better respond to the pandemic. It is an effort to break the barriers to accessing COVID-19 medical products, realizing that a case by case or product by product approach required when using flexibilities. Hello?
Sorry about that, Candice, it was an unmuted mic, I've muted it.
Okay, all right, cool. So yeah, so it was in response to having a more sort of automatic approach in terms of addressing this issue around IP barriers, instead of using like a case by case or product by product approach. So as you might guess also, which is very unsurprising, that several high-income countries have not come in support of the waiver, making statements like, I'll actually just highlight some of some of the arguments that they come with in trying to take away from the proposal that has been made by South Africa and India. And one of those is that IP is not a barrier, which is something that we have seen. And as I mentioned, during the height of the HIV and AIDS pandemic, we've seen millions or rather thousands and, thousands of people dying as a result of, not getting access to these life-saving ARVs, and not because they were not there and available, because they were too expensive to afford, and because of the patent system, it that didn't allow for countries to actually get access to these life-saving medicine. And I've actually also showed you with these examples that how actually patents can affect access to these medicines. Secondly is that IP-enabled R&D in COVID-19. So in most of the cases, governments or even pharmaceutical industry would refer to IP as an incentive system to incentivize them for all the funding that they have put in developing these products. What we see and what we're actually realizing now more than ever is that actually it's not just pharmaceuticals that put in money into the research and development. Public funding and global collective effort enabled R&D in COVID-19 in making of these COVID-19 products. And we've seen with the vaccines, various governments, public institutions, taxpayer money went into funding the development of these drugs. So it can't be just that that we as citizens put in money into that, and then pharmaceuticals come back and say that, oh, we've done all the work and therefore it's warranted for us to have some IP to sort of protect ourselves and to get the kind of returns that we are getting from the products we've made, because we've put in so much. So what we see now, and you've seen with the vaccines, that they're mostly publicly funded. And I think one thing that also needs to be highlighted is also the funding that goes into clinical trials. South Africa has been involved in, I think, 4 clinical trials, 4 vaccine clinical trials, that, in as much as some of the funding came from international organizations. Some of the money that actually went in some of the clinical trials that were done in South Africa came from South African government. Some of the state resources, need to be accounted for and valued in terms of, the contribution that South Africa has made, and therefore we should still stand to benefit from that. Thirdly, is that voluntary license is sufficient. I think this still, we can't rely on voluntary mechanisms. We can't rely on pharmaceutical generosity for us to actually get access to this these life-saving products. I think they've shown us that they will continue the way they do things, still continue to profiteer even in the face of a pandemic. They'll still continue making profit over saving lives. For we can't rely on voluntary mechanisms, and in fact, the WHO has also set up a mechanism where pharmaceuticals can sort of put
I think let's just give Candice maybe a moment or two. I think her connection might have disconnected. Let me see. Hi, Candice. Just hold on, guys. I'm just going to try contact her on the phone. Apologies about that. As she had said that her connection was a bit unstable. I think we can maybe just give her a few minutes to log in again. But in the meantime, some of the stuff that Candice was talking about regarding IP laws, it kind of builds up from what Fatima was saying, and she was just giving more of a historical context. And when we look at issues of IP law, right? Yesterday I was telling you guys about the story that I did in August. Oh, sorry, my video is off. I was telling you about the story that I did in August about pandemic profiteering, and how when I sent a query to government to ask them what was happening in terms of vaccine procurement, right? And they were like, no, we like, they didn't want to say anything. I don't know if there was a plan or there was no plan yet, but their response was saying that they have good relationships with pharmaceutical companies, and therefore they will be able to secure, they are in negotiations with the pharmaceutical companies. And at the time, activists and MSF, even Fatima and other activists in the IP and equitable access of medicine space was criticizing the government, because they were saying that you can't depend on the goodwill of pharmaceutical companies. You can't think that pharmaceutical companies are going to be these like charity or like very gracious organizations that will just give you access. And things like like doing what Candice was talking about when she was talking about how Denmark did how compulsory licensing, like Denmark did, allows governments to be able to procure medicine even when pharmaceutical companies are against it. This is some of the things that we need to report about, that in cases where we find issues with patent laws because they're being enabled by government. A question we need to ask ourselves: why, in that study that was done by the Fix the Patent campaign, why is government, why is the South African government accepting or approving patents for medicines more than another, what we can say, a global South country? For instance, Brazil, economically, inequality levels, we're very similar to Brazil. why is Brazil more strict than us? What are the things or the policies that we have in place, or what are the political commitments that make it impossible for our government to make sure that medicine is available for everyone? Yesterday I also shared an example of the Thobeka Daki, who was part of the Fix the Patents campaign. She passed away a couple of years ago, and her, like, if you just even Google her name, I'll put it into the chat. But Thobeka Daki had breast cancer. She had medical aid, but she still could not afford the medication she needed to the medication she needed to fight her breast cancer. In 2016, the medicine that she needed was Herceptin, which cost about 150,000 Rand for treatment, and this was in 2016. So now imagine with the inflations and everything. And so when we ask ourselves, when we talk about equitable access, particularly now in the case of COVID-19, what are the measures that the pharmaceutical companies are putting in place to make it hard for poor people in the communities that we come from accessing healthcare? At least, with when you're seeing with the government announcing that the African Union announcing yesterday that they have procured more doses for African countries, and the worst affected countries are the ones that are going to get more doses. That's great. That shows us that in cases where there are policies that ensure that people have equitable access, that it's possible to get that equitable access. It's so great to see that Candice has been able to join us again. I'm just going to hand over to her now. But these are some of the things that we, just as she sets up, these are some of the things that we need to think about. Is our government creating policies that protect its citizens, that ensure that its citizens are able to get the healthcare that they need? Or are we simply just living in situations or in a country where there is not enough laws and policies that protect us as its people in case we get sick? Candice, you can go ahead.
My apologies for that. I had an internet issue, but I've just moved to using my phone, so I won't be able to project my screen. But I was just left with actually just 2 slides. So I think I'll just run through it quickly, and then we can do a question and answer session. But that's fine.
That's perfect. I'm just going to put up I'll share the presentation from my side just now.
Okay, cool. Thank you. So sorry about that once again. So as I mentioned that, where was I? I think I was on the existing TRIPS flexibilities are sufficient. So we've heard a lot from the government, or rather, especially your high income countries, that, but we have TRIPS flexibilities that should, be that should be sufficient to ensure access. But what we are seeing that there are some limitations with the current flexibilities in place. As I said, that it would also require us to do a case-by-case work on things on a case-by-case basis, but also considering that South Africa hasn't also incorporated these flexibilities into their national law, it would be very difficult for us to actually implement some of the flexibilities in these during this time, because we still have to reform our current law to incorporate these flexibilities. So there are some limitations, and considering that not all countries have actually incorporated these, which is obviously a problem, but and we hope that it would be expedited, but we can't rely on the current mechanisms because of such limitations. So global initiatives like the COVAX facility, ACTA, can deliver equitable access. What we see is that, as you also might have heard, that South Africa, well, countries like South Africa and many low and middle income countries will rely on the COVAX facility, and the COVAX facility is a mechanism that has been put in place by the WHO, Gavi, and CEPI to allow for your low and middle income countries to access these vaccines. Sort of like a pooled mechanism to allow for equitable access. What we're seeing that with the COVAX facility, it's also in as much as we will be relying on it, but it's not a system that we can fully rely on because of a number of things. That firstly, it's not delivering the vaccine on time. We still have to wait until Q2 for us to get the vaccine from the COVAX facility. What we're also realizing now is that we're actually paying way much more for the vaccine versus your high income countries. And a recent thing that happened in December, we had the Belgian official share, the pricing of how much the EU would be securing vaccines through bilateral deals versus, I mean, they shared that information. What we saw from that is that we're actually paying way much more through the COVAX facility versus your high income countries that the EU is paying through their bilateral deals. And also the fact that wealthier countries are, getting into these bilateral deals, it's also undermining the initiative of the COVAX facility to be able to secure vaccines and deliver to low and middle income countries. So I mean, in terms of the COVAX and all these initiatives, there definitely is some flaw into it, and there's still some room for improvement for them to actually better serve countries, especially countries like South Africa that will be expected to self-finance when joining the COVAX facility. Second last one is, even if IP is removed, developing countries cannot produce COVID-19 technologies. I think this presumption has been proven to be wrong, and showed an example of our capacity to be able to produce Roche testing kits. What we see is that we actually do have the capacity to make these products, but because we don't have the IP rights and know-how, it makes it difficult for us to be able to do that. Last one is that IP holders are the best to produce safe and quality products. Developing countries can produce products with robust quality and safe, or rather, the reality is that developing countries can produce products with robust quality and safety, and that whole notion that we produce poor quality is also a myth. So in terms of equitable access to a vaccine, so I mean, this, we will see a Johnson & Johnson logo on there, but I think it also applies to all the vaccine manufacturers or producers, that for us to be able to get access to this vaccine, there needs to be full transparency, first of all, full transparency of how much the companies, how much it actually costs to make the vaccine, how much they are charging countries, because now countries are also going into non-disclosure agreements, which basically limits the transparency, limits how much we actually know about the product, or how much these countries are buying or purchasing these products. So there is a need for full transparency on that, so we can better hold them accountable. So openly share and don't enforce intellectual property. There's a need for sharing, as I mentioned, that there's issues around shortages, issues around not enough global supply. This can be eradicated by sharing of intellectual property to allow for countries that do have the capacity to be able to manufacture these products. help others to make more doses of new vaccines. This also speaks to the idea of sharing and collaboration, which I think the TRIPS waiver is actually wanting to do that, to enable a system where there will be open sharing and collaboration amongst these companies, and then shared doses with developing countries. As you know, that your high-income countries have secured most of these most of these vaccines, and yeah, so companies have also, these manufacturing pharmaceutical companies have sold most of their doses to high-income countries. There's a need for that to be shared equitably amongst countries, to allow for countries, especially your low and middle income countries, to be able to get access to these vaccines. So I think that's all from my side. This is just a slide that was mainly targeted at the government, that that there is a need for them to support mainly the TRIPS waiver, and which side of history will they be on? Is it saving lives or profits? And I think at the moment the current system and the government actually allows for that, for pharmaceuticals to be protected by the system, and things need to be different, especially now in the face of a pandemic where thousands and thousands of people are dying. We need to do better, and we cannot rely on measures from your pharmaceutical. There has to be some government sort of willpower, and also in them enforcing some of these things, and they can do that by changing our practices, our policies, our laws, to safeguard public health. So thank you for that. And I'm open for questions.
So much, Candice, for that. Just to say, if you could reorientate your camera, especially for the question and answer, that way. Thank you so much. Just before your connection broke there, I was just explaining, some of the things that you're saying, and how you actually, just for the curiosity, for me to understand how the WTO works, TRIPS, and all that stuff. Candice is the person that I think we had an hour conversation last year, and that's how I got even into understanding what these things mean and how they affect me or everyone in South Africa. And as you were disconnected as well, Candice, I gave an example, an old example, not necessarily related to COVID, about equitable access, Tobek and Daki's case, and how she could have gotten the life-saving medicine if it wasn't for the patent laws that existed in South Africa at the time, and it literally cost her her life. I think one of the questions, Candice, to just started off, is how can we communicate about the importance of IP laws, equitable access? How do we make it relatable to our communities? How do we, because it can seem so high level that this does not really directly influence me, or directly affect my life. So how do we measure, how can we talk about it as journalists in a way that helps our communities to understand the importance and the power that they have in also challenging government in this case?
Yeah, thanks for that question, Bonso. I think it is, we won't deny that it is quite a very niche area that requires, I don't know how long it also took me to actually understand some of these things, but I think there is a need for us to sort of break it down, bring it down to a level where it's easily understandable for ordinary, or rather anyone basically to understand. I think it is a responsibility, and I think it's great that we also have journalists also to rely on, because we've also relied on quite a lot in terms of sending the messages or communicating around these issues. But I think there is a need for us to bring it back home. I think COVID-19 provides that opportunity for us to actually debunk on these issues, talk about it in a way of how do you put it, in like a very practical day-to-day thing, like making an example of a chair, in trying to make sense of how IP affects, or rather how IP affects, innovation. I think it would take us, first, I think the language is quite an important thing. What kind of language we use, and that's in most of the cases, if we're doing our trainings, especially because when we do our pickets, we often have to train the people who will be joining our marches and supporting us. In most of the cases, we have most of the activist guides translated into a language that would be easily understood, so be it Sotho, Xhosa, Zulu, whatever. So I think that is one of the ways in which you can speak to people in a way that it's easily understandable in their language. And secondly is also using your day-to-day thing to make examples of how the concept works. And that's what we also use in terms of our trainings, that we don't, because sometimes, using like the issue around medicine and stuff, it's so far-fetched, and molecules and all that is so far-fetched. So how about we use things that are practical, like a chair in the house? If you just tweak just one thing, do you think that it deserves to be given a patent or not? So it's really just trying to use your everyday thing to try and make sense of it, and not using like your big words that would completely lose people, like things around. I mean, I think we do use like the word patents, but often people don't know what a patent is. The word monopoly is probably more common language, especially in South Africa. It's probably more common language than using a patent. So maybe using those words that are actually easily understood by anyone. There's a time where monopoly capital was like a big thing in South Africa, and everyone understood that. And essentially what a patent is actually speaks to the monopoly system. So using that to actually also drive that messaging, and using common language that could be easily understood by people, that is also quite big at the time. I think it's also quite important to actually contextualize it in that way.
Thank you so much for that, Candice. Lucas, I think he sent me a direct message by mistake. He says equitable access was going to be achieved if the NHI was implemented. So now I think we're heading for a situation whereby the wealthy with unlimited access to private healthcare will have more access to quality drugs. And how does access to medicine fit into private, like the private versus public healthcare kind of debate, or what is the link between private healthcare versus public healthcare when it comes to medicine access?
So I think, the issue around patents, I think it's also a bit high level to that point, that in as much as you might, if even if like I don't know if it can be, there is some link in terms of the private and public, institution, but it actually affects us all, whether you're in a private medical aid or we use a public system. If a product is patented, that company can decide how it will be accessed, and you find that some products that you would assume that are available through the private system, actually not even there, because the government actually or rather it's easily accessible for the government for them to procure through that system. So I think even now during COVID-19, I'm actually glad also that the government is also using like a singular system, that it's not just private sector buying their own, they're using like just one mechanism or rather procurement system that would be government purchasing all the vaccines through like a government system, and then distributing them throughout, be it private or publicly. So I think issue around patents, it does to some extent affect, in terms of your public and private, but I think it's also an issue that goes beyond, it's a bit high level beyond just the, that distribution level.
Thanks for that. I'm not seeing any questions in the chat box, but I was wondering if anyone wants to ask Candice a question while we still have her on the line, because I'm sure she has so much work to do and we just asked for an hour. Okay, Candice, can I also share your email address with the journalists in case they want to send a media query and ask anything regarding this code? I'll send the presentation to them, and I'll just add your email address there for you to be reached.
Okay, that's great. I'm more than happy to answer questions if you need. And as I said, I think it's quite good also that we're having this community sort of engagement. I think there is a need for especially people on the community level to understand these issues, because I think it's also quite easy to. I'm not saying that with the government that they're doing everything right, but I think there is a need for us to sort of fully understand, some of the dynamics and some of the challenges that actually even the government, that even they might put in effort to do certain things, but because of how their global, system works, it makes it even more challenging for them to do certain things, and often they would be at the receiving end of criticism, but I think it's very important for us to get a full picture of how things come about, what affects government even doing what they want to do, and I think we need that understanding also at a community level. I think there's a lack of that, so I'm glad you guys invited me here today, and I hope it was helpful in some way.
There's one last question, Candice, here from Lungi, who says, I remember that for a while there has been civil society has been trying to get government to change the current patent laws. If I'm not mistaken, MSF was part of that movement. How far has it gone? I'm wondering about the issue of the vaccine as to whether the patent laws affect its provision in any way. So first about what has happened in terms of changing the IP laws and the patent laws, if anything's happened, and how do those feed directly into access to COVID vaccine?
Yeah. So as I mentioned that this bit of work, so MSF is still involved, and this bit of work we do it with Fix the Patent Laws, which is a coalition of 40 organizations. So we're still pushing for this reform to happen. It's been 10 years now, I think, of trying to push for a patent law reform. So at the moment, what we have is an IP policy, which reflects some of these TRIPS flexibilities that I highlighted on here. And then now for it to be exercised, because an IP policy it's good, it's a good step, but we need that to be incorporated into our national law for it to be effective and exercised. Until that happens, it's actually as good as nothing if it's not, that IP policy is not turned into national law. So now what we're doing is pushing for the IP law reform. So now the government is going into sort of a law sort of reform process, and we're pretty much involved in that in that process of getting a bill. There's going to be a whole long process still, I think, in terms of reforming, because as you know, it's not an easy sort of process in terms of changing the law. So now we're anticipating to get a bill in the next few months, hopefully. And then from there will be some, open to public comment, and then there will be a parliamentary process, and then eventually turned into law. But that is something that could take, we're also not sure as to how long that will take. We're still pushing for it to be expedited. And how that affects, vaccines, as I mentioned, that in some cases we could, either issue a compulsory license, allow for, and as much as South Africa has also you know, and I think with the vaccine and manufacturing of a vaccine, we don't necessarily have the capacity, or rather full on capacity, to manufacture our own vaccines. I think it would still help if we were, you know, to have some kind of a policy to enable us to either do the fill and finish as we are doing now. So in terms of some of the you know, in the eventual, you know, instance that we do get, or rather we do have the manufacturing capacity, this would sort of assist in enabling us to be able to do our own instead of relying on other countries. So yes, I mean, at the moment it does not directly affect, also because we don't sort of hold the IP, or we do not sort of we did not sort of produce any of the vaccines. So it doesn't necessarily directly affect it, but I think in some way also in the future, I think it's still necessary for us to have these national laws to prepare for the next pandemic, but also in terms of, you know, building our capacities in terms of other things, like your diagnostics, medicine as well, that we can produce it. It's still necessary.
Thank you so much for that, Candice. We will send you Candice's presentations and her email address so you can contact her. Thank you again so much for joining us. We really appreciate the knowledge. All right.
Thanks a lot. Bye.
Thank you. Bye. And with that, you know, I think we're almost at the end of today, and I just wanted us to spend a few minutes on just brainstorming, if you guys are open to it, kind of like different story ideas that are possible about the vaccine. I think one of the things that I had already mentioned was, you know, using the booklet to kind of do just a Q&A on how the vaccine rollout is going to work. And I just want to quickly, I had found a link to a story from my previous employer that really, I think it's something that is really, excuse me, you know, like yesterday as I was speaking about how people are reading stories that are really more about, they want information on what the rollout plan is. And so I'll share my screen just now. It's just opening up the link again, and there we go. So this is, a couple of years ago, I used to work at Vexisa. And so this is after the press conference that happened on the 3rd of January, where the government was sharing the plan, right? You see, this story, just want to show you how it works. It's really everything that was said by the government, you know. They published what the strategy is about, like a small brief, a brief description of the strategy and what were the main points, why vaccines matter. And they then did graphics about how the phases are going to roll out. This is a story that we'd call an evergreen story, because many people are going to go back to the story for many months to come as vaccine rollout happens. When people want to know who in South Africa is going to get the vaccine, how is it going to work? So these are ways in which, without even doing an interview, just listening to maybe a recording, I'll just stop sharing. I'll send you the link to that article as well. Let me do it right now before I forget. Without even having to do an interview, an extra interview, without having to but just by listening to a press conference and going through the material that the government was presenting, and then putting it in your brand colors for your publication, that's a story. You're informing people, you meet a deadline, as I was saying yesterday, and you have a story that will be useful, that will always get hits on your website if you do have a website. And these are innovative ways in which we need to think about, in the realities that we face, we need to think about the stories that we create. I don't know if anyone else has ideas of how they would, like after the 2 days training, if they have any ideas on how they would cover the vaccine rollout, or even just what a vaccine is. Anyone wants to share if they've come up with any story ideas. And I think this is a safe space to share that, because you know, a lot of us are like, we're from regional papers, so it's not like you are going to be competing on a national agenda. Someone from Limpopo can write the same story that you're writing, because it's not necessarily going to be the same audience that reads the story. And I think it's important also, you know, like one of the main things that people have been talking about around what is important about this pandemic is that journalists are able to, it has also increased collaboration within the journalistic field. And so this is an opportunity for us to talk about these stories, and also so that if you do need any help, obviously you have my email address. If you would like to just talk, maybe privately if you don't want to share. But like I also said, we are going to be sharing the audio version of the 2 days. I think particularly you may want to quote the experts that we had, Candice and Fatima. If you want to write a story, I think you can use their material. As part of a direct quote for a story. So we'll share that audio so that it's available for you. You're able to cut any parts of it. But I just wanted to just quickly, you know, briefly talk about story ideas. If you feel you're ready or you can write a story, because I know many of you said you were not able to write, or you stayed away from writing about or reporting on the vaccine. But do you feel equipped now to go out and maybe do a story about the vaccine? Or do we need another 2 days next week? So some of the story ideas that I like, I think yesterday, I'm looking through my notes that we discussed, you know, Q&As with basic explanations of what vaccines are and how they work. We can also do Vox Pops. Lungi, I see your hand is up. You'll speak just now when I'm done. You can also do Vox Pops. You know, this on Monday on Motsweding FM, they asked people, you know, what do you think about vaccines? And doing Vox Pops is always a great way of finding out whether your community, like how much more information you need to provide to your community. So on Monday, as I did explain yesterday, I do like a 5-minute segment on Motsweding doing COVID updates every morning. On Monday after, or it was Tuesday, I don't remember, this week has gone by so fast. Early in the week, after listeners were asked what is happening, like what do they think? Do they believe do they believe in COVID as the pandemic is real? Would they take the vaccine? And a lot of people are saying no. What that presented an opportunity for the breakfast team at Motsweding is to then next week maybe focus more on explaining vaccines. What it did for me, somebody who explains COVID every morning on Motsweding, is it gave me a knowledge that perhaps maybe we need to go back to basics, that even before we talk about whether or not you're going to take the vaccine, we need to explain to people the importance of a vaccine. And so Vox Pops also allow or enable an environment where you can gauge how much knowledge. It's a way of almost doing like audience research while doing a story, because it allows you to know how much more knowledge you need, or how much more, what kind of stories that you need to write for your community. Lungi, go ahead.
Hi, Panto. Yeah, the sessions have been very helpful. I mean, I'm sure there's a lot of there are a lot of stories that will probably come out. I mean, some of the thoughts that I had as ideas were around the issue that the matter that I asked about to Fatima yesterday, where we were asked about, the length of the vaccine and how it actually influences some of the thinking, that the vaccine is not effective. So I mean, I remember she said that one could speak to like researchers, who can actually explain why it had to take such a short period for the vaccine to be produced, and the effectiveness of the vaccine as well. And then
Yes.
the other one was on
Yes, go on. Sorry.
the other one was like looking at the rollout plan and what government would need to do to ensure that like the plan works out. Because I remember Fatima was saying as well that this is the first big, I mean, like massive vaccine rollout since I don't know, like I think she said
Polio.
50 years ago. So
Yes, since we had
it would be
vaccination for polio.
yeah. Yes. So, I mean, it would be looking at the nitty-gritty details of how this would need to be rolled out in order for it to be effective and for everyone to like benefit from it. Yeah. And then I was also thinking the same thing about Vox Pops, even asking people about whether they will take the vaccine or not, and reasons as to why they would or wouldn't. That's all for me.
Thank you, Lungi. So I remember that you asked that question, and actually I had bookmarked this page. I just shared the link now in the chat box. I had bookmarked it yesterday. I did a little bit of research to find out. And this is one of the most reputable sources that I found on your question: how and why, how was it possible to develop a vaccine so quickly? I looked at the sources, and it's reputable. Sorry, now my brain, I just had a brain freeze there. It's reputable experts from reputable universities and research centers. So it's obviously US based, but this could help in explaining it as well. And I think they even quote, in there you'll see there's a study that has been quoted there that was published on how and why it was possible. And so that's an answer. And then you can even see which the experts that they're quoted, like what their qualifications are. So you remember that idea of trying to find your local university and finding the public health department. So maybe perhaps looking at they're the professor of vaccinology or whatever, then you're able to maybe search the department of vaccinology or some similar profession like that as the same as the US experts in that story. I see Mahmoud also saying that I think this is a very important story to write, also countering the misinformation. I think there's very little journalism on this that is happening. And I think this is because another source that is very good that I forgot to add into the resource list is Africa Check. Africa Check, they fact check, and they have a lot of materials on. They've done a COVID-19. They have COVID-19 fact checking happening, and it's usually you can reprint this without paying for it. So if you're a small publication and you don't really have the time and you don't have the time or the resources to really do this in-depth research, Africa Check has done it for you, and it is possible for you to republish them, and you don't need to pay for it. So what I'll do is I'll send an updated list of resources, add them. They're also on WhatsApp, where for the radio guys, where you can get, and I'm sure maybe you know it, where it's called, they have a WhatsApp podcast that is called What's Crap on WhatsApp, and it's really dedicated to combating misinformation and fake news, and they send out little clips, you know, and I do think also those clips, obviously with giving them credit on air, you're able to play that clip that targets the certain misinformation, and you're able to play it on air. So I'll add those to the resource list, and Chiwa will resend it with the WhatsApp number and the website and how you can get it. Tidisa also saying that the important thing to do is just to make our communities aware that the vaccine is here and is here to save them and not to destroy their lives, as it has been said. We need to start reporting as we are ready now and get rid of the false theories surrounding the vaccines. The first thing is to make our communities understand what is a vaccine. Yes, and I think, you know, sometimes, you know, before we even talk about the vaccine equitable access, we need to put ourselves in the shoes of our readers and our communities to be like, can I really talk about IP laws and patents before they fully understand how and why and what a vaccine is and how it works and why we need it, you know? So it's almost like going back to basics. And in the presentation that I had prepared, that we didn't get a chance to do, but will be sent to you, one of the tips that I put there is that there is nothing wrong with repeating the same information, and there's vital information that you can repeat, you know. I think in the beginning of reporting on COVID, we always had to repeat social distancing, washing and sanitizing hands, and the importance of wearing a mask. And now, I think especially when we're seeing people also become very lax about their mask and everything, we need to keep on repeating that, but now add a layer to it about vaccines. Vaccines work in our bodies to help prevent diseases. How do they do that? They do that by creating antibodies. What are antibodies? Antibodies are, I usually say, they're the soldiers of your immune system, and they help fight the virus or the disease when it presents in your body. So the vaccine enables your body to be able to create antibodies, you know. Sorry, I know this from the back of my head now. So these are some of the ways in which we have to break it down step by step for our readers. And this is the only way we are going to indeed win the battle, Tidiso. Fanazil is saying that building COVID-19, his stories, ideas around building COVID-19 vaccine trust in the community. And much like what I just said, you know, it's really about starting back to basics. Do not assume people know. You know, there's been a picture doing the rounds on social media of people. It's a joke, and I think it's belittling, but it's really funny where it shows a picture of someone's forearm and it says this person doesn't want vaccines, but they have been vaccinated because in the olden days when you're vaccinated, it left you with marks, you know. And so maybe perhaps when you're doing your vox pops, you ask people, can I see your forearms? But do you know that you were vaccinated? You know, and explaining it, or maybe taking a photo like that of many people in a photo essay of people with the marks, to show that, you know, most of us are alive because we are vaccinated. We need to find different ways and creative ways, and also ways that don't belittle. You know, fake news is wrong and we can't encourage fake news, but we need to also be empathetic to our communities, that not everyone who's spreading fake news is spreading fake news because they're trying to be malicious or they're being naughty, or, you know, they're trying to cause disruption. Some people genuinely believe in this, and it is our responsibilities as communicators, as media practitioners, to provide information to combat this and to teach people the right information. Children's Radio Foundation, we have a slot on SAFM every Friday. That's really great. I've heard it. I've heard you guys on SAFM. It would be nice to get a vox pop covering people's thoughts on what they think about vaccines IP and what they think about the vaccine itself, and if they will be taking it or not. Would be great to capture comments with participants who have attended this workshop. So I think Gabriel's asking if, you know, he can contact you guys directly that were part of the workshop, and please do let us know if in the chat if you're okay with Gabriel or you can message him directly to say, or just say, yes, I'm okay with being contacted, so that we can do the exchange of numbers. And also, while we're here, or rather of email addresses and contact details, while we're here, I would just want to hear from the group as well. Are you open to us sharing everyone's contacts with each other? So if you want to talk to Lungi, who's in KZN, or someone else in another place, are you guys okay with us sharing your contact details with each other, so that it is not too much of a schlep if one person wants to get a hold of the other one, and that I do not, myself or Chiwa, do not become the gatekeepers of conversations. Notando also saying that we need to start reporting on vaccines and make our readers be aware of vaccines will help with the virus and doesn't kill people. But on my side, it's going to be tough, and I'm going to try my best, because people, they believe that Mhlonyane is a cure. This is true, because of all the misinformation. It's almost like we have to repeat and do the same story many times. But I guess this is the boring part of reporting during a pandemic, repetition, but it's important because that's how we're going to ensure our communities are safe. Bipelo also sharing that the importance is to elaborate on what the community needs to know, like the side effects, to clear the myths around the vaccines. We read many stories whereby health workers have allegedly refused to take the vaccines due to reported side effects, which people don't really know about. This is a very important point, Bipelo, and in hindsight, I did not really dwell on that. Vaccines can have a side effect. They're very rare, and this is something that we also need to say. Studies have shown that it's very rare to get a side effect. I remember a couple of weeks ago, there was a photo of a nurse, I forgot which country, she was getting vaccinated on live TV and she fainted, and a lot of reports started saying that she fainted because she got the vaccine. But in fact, she had another medical condition that caused her to faint. Right? What I've seen more people sharing that the nurse fainted after getting the vaccine than people sharing the corrected information, but also it's important to talk about side effects. There are side effects to any medicine that we take. However, like in explaining the process of how vaccines are approved, if it had adverse side effects, like really bad side effects, it would not have been approved by the World Health Organization. It would not have been approved by the Department of Health and other reputable international organizations. That is what, and maybe perhaps explaining the procedure, like for example, in this morning on Motsweding FM, what I did is I was trying to explain the procedure to the listeners on how a vaccine becomes available or is used in people. And so these are simple ways, reiterating information like that, literally telling them, I was telling the listeners that, before even they're tested, a vaccine is tested on humans, there are animal testing that is done. Only if animal testing results are safe and considered safe, then we move to a small group of people. And once scientists have seen how the drug works in people, then we do large-scale clinical trials, right? And this is how clinical trials work. These are the authorities that are in charge of approving. And if a vaccine is seen to not be safe, it would not go into let's say a large-scale clinical trial where we see some of the vaccines are. And also it's very important to also, a question that I've seen a lot of people ask is, but China or Russia, other countries have started vaccinating, why haven't we started? Because South Africa has chosen to take the long route, which is also the safer route. By that, I mean that some countries procured vaccines that have not even gone to phase 3 testing, where they have not been tested, or the results of whether it works or not have not been proven or shown. It's an experimental vaccine, but because they're scared, the governments of those countries have then decided that they are okay with using a vaccine without knowing whether or not it works. South Africa could not do that because we do not have the money to waste. Imagine we buy a vaccine that we're not sure if it works or not. That's hundreds of billions of rands that would have gone to waste. So even though this is the long route, it is better and it's safer to wait for an approved vaccine that shows that it works and it's efficient, or its efficacy is very high. And okay, I see most of you saying that it's okay to share the contacts. We will really do share the contacts with everyone. And is this trying to open the photo that you just shared, Sidiso? Just hold on. So I can I can tell you now, this is fake news. Look at the spelling of COVID is not correct. This is not the font. Maybe let me just share the screen so everyone has seen it to show. Sidiso says he's just seen this on Facebook. And this is, I'll just show you how it's easy to just debunk this as fake news. So you see this, look at this photo. Look at it. You can see it's not high quality. Do you see that? It's not high quality, it's pixelated. Daily Sun is owned by Media24. Media24 has some of the best graphic designers in the media industry in the country. They would never have a poster that's this low quality. COVID is misspelled here, as you can see there. So you can already debunk it. I'll try to quickly also download or show you guys. I have recently deactivated my Facebook, but I will quickly just log in because I want to show you what a Daily Sun poster actually looks like. So, you know, this is something simple that it doesn't have to be a story, TD. So on your publications Facebook page, you can share this and say fake news. This is fake news because, you know, this or that. Or you can even send it to Africa Check that is equipped and has a team big enough to fact check it. And then you republish it on Facebook to show that it's fake news. But it's very clear. It's often very easy to also determine if something is fake news. I'm just quickly searching for Daily Sun on Facebook to show you how their posters, they do have posters similar to that, but the quality is much, like you can see the difference in the quality. And these are the small ways in which, you know, we can also help our communities. When we see the fake news like this, simply just go to the Daily Sun poster or to their websites to see if the story is there. I've downloaded one poster. I'll share it just now. Hold on. Where's share screen? So here's a Daily Sun poster. I wish I could. I don't think I can share both, but you can see the other image, how different it is, right? Like it's not the same. It's similar, but you can also see the Daily Sun poster even has the date in which which newspaper or which story it's for. So you see this is for today's Daily Sun. So these are simple ways on how we can also become more aware of fake news to help our communities and help our readers see to do this. Thank you, Tumelo, for also saying that. I know you said that you were not encouraged to write COVID stories, but I'm so glad that, you know, this training has offered you an opportunity to think that, to have the confidence to write it. It's very important. And thank you, Mahmoud, also for sharing fact-checking sites. This is a very great resource. I'll also add it to the list so that it's there. But, you know, outside of that, thank you everyone for taking out your time during this very busy beginning of the year to attend a virtual training. We know we left Zoom, the 2020, I was tired of Zoom at the end of December, or in the middle of December when we took the Christmas break. I could not do another Zoom meeting. And 2 weeks later, we're back at it. I live on Zoom yet again. And so I know it's difficult times. Thank you so much for taking out your time, for interacting, for asking questions to the guests, for giving your opinions and everything. It's really been, I've learned so much from even listening to all of you about changing or even like I have my own story ideas that have come out of listening to your your stories. And as she was reminding us, one last thing we really need, I would really like for all of us to switch on our cameras so we can take our Zoom selfie. It will just be for a few seconds. So I will also we'll share the selfie on via email with you all as well. I see some people are even wearing masks, which is great, you know, as we're talking about masks, sharing and everything. So once as many people as possible have their cameras on, we will take the Zoom selfie. Let me switch to gallery mode. And please do send any feedback. If there's something that you did not like about the training, we'd like to also hear about it so we know how to improve it in the future. It's very important, particularly for me as somebody who was facilitating the training to get some feedback. To get some feedback from you guys. But thank you again. We will send resources. If you ever need any resource, if you're not sure, I'm an email away, and you can really email me and I will try and help you as much as I can with any of the resources. So let me just quickly, assuming those who don't have their cameras on would prefer not to, which is okay as well. So I'm just trying to change this to see, to gallery view. Okie dokie. Okay, hold your smile in 5, 4, 3, 2, 1. I see some people don't like smiling. Let me just take another one for backup. Awesome. I've become a Zoom selfie expert. So if you ever need lessons on how to take a Zoom selfie, I'm the person to call. Thank you again, everyone, for joining us. And this was really, really a wonderful 2 days. And we hope to keep in touch, and we will just create a document with everyone's email and share it around. Thank you. Bye.